women get either more fed up or are experiencing more violence, they start to increase their actions. And one of the key actions women in this setting took was to visit the clinic, especially when they wanted to access formal services. Beyond visiting the clinic, very few women reported to police or would press charges. Just to give you an idea, visiting the nearest police station from these settings is about 45 minutes to an hour and a half away. So you can imagine very few women take those actions. So then we wanted to create a plan with stakeholders from the region who knew how best we could respond to this violence we're learning about. And we built up a 4-stage plan. I know you can't read it on this slide, but the 4 phases were to start first outside of the clinic. Let's build up the networks of the local informal services. So for us, this included police, social workers, counselors, just normal neighbors and community leaders that could help come together and create an informal network of responding to violence. We used a number of good community resources from a website called SASA. It's from an NGO called Raising Voices that delivers a lot of really interesting community discussions and posters. Then we trained all the clinic staff at one local clinic. And we wanted to do this because we thought not only are nurses and doctors key to responding to violence, but also every other one of the staff persons at the clinic is key. So we engaged them in thinking about violence in the community and then worked towards practical skills, post-rape care, dealing with violence in children, and then responding to violence in a way that's confidential. We then tried out our new system. And the first tool that we used is on the left, a screening tool with 6 questions, very similar to the questions that Dr. Mak'anyengo was just going through. We asked our clinic staff to screen all antenatal clients. Then on the right-hand side was another tool that was a referral tree, and this referral tree was used by the clinic staff to help refer women to informal services. Again, not always the police or NGOs, but maybe the local headman or a social worker in the neighborhood. A very key part of this was a group called the Community Referral Persons, who were lay counselors that were trained to escort women to additional services. Because one thing we know is that just handing women a slip of paper with a referral is not sufficient to get them to the services they need. So these escorts, called Community Referral Persons, helped women with transportation and a friendly face. We learned that of the more than 100 women screened, 39% screened positive for experiencing violence or being at risk of violence. As you can see from the small chart on the right, the numbers screened decreased a bit over time, and we're curious, is that because the clinicians lost a bit of enthusiasm over time, or is there some other reason? We really need to learn more about that. But ultimately, people were very supportive, and one health worker explained, actually, it's really helped women because before the start of the pilot, they didn't know what to do, they took no action. Now they know where to go. So now our job is to take these lessons and refine the intervention, making it better. We found a lot of remaining challenges that we want to address in later versions of this intervention. Very few women wanted to press charges. And in an antenatal clinic setting, that makes a lot of sense. Pregnant women may feel dependent emotionally and economically on their partners. It's unlikely they may want to press charges at that point in time. We can still connect them to better services, though. Another challenge was that some of the informal systems, like family members, village elders, they would sometimes support the man instead of the woman. And so in an ideal world, we'd want to improve the way that they support women, especially if those are the kinds of referrals that we're making. So we obviously had some shortcomings. It was a very small pilot in one setting, and we only evaluated it after the fact. But one thing we'd like to do in the future is learn specifically how this impacts the antenatal clients themselves. Do they like it, and is this useful? The other thing we need to learn is whether this improves women's health in comparison to places that don't have these services. one challenge and a call for action that I have for this panel in the room is that the evidence base for this kind of work is very limited. And one challenge is that funders often don't want to randomize a study which gives some GBV services to the intervention group and gives no GBV services to the control group. So it's a challenge because we have very little evidence about what works and why it might work. And that's why this panel has become, for me, quite an interesting start to learning the emerging findings. We hope that this might be a good low-cost solution to preventing further violence towards women. And I'd really like to acknowledge two people in the room today. The first is Janet Turan, who's the principal investigator and has really spearheaded this work. And the second is Merab Odero, who led all of the study coordination and worked very hard. We also had excellent teams that helped deliver the intervention at our clinics. Thanks very much.
Thank you, Abigail. The next speaker will be presenting two abstracts, and it's Dr. Esther Mzilangwe, and she is a psychiatrist at Margaret National Hospital, and she's also the GBV Program Officer for MARCS under the Tanzania AIDS Prevention Program. And she is presenting on behalf of Rose Linson and Samuel Likindikoti, who unfortunately were not able to join us. And the first abstract will be findings from a pilot study on the use of a screening tool for GBV. And the second will be lessons learned from a pilot program to screen and provide GBV care in selected health facilities. Thank you.
Thank you for this opportunity, and I would like to present on behalf of my colleagues who are currently busy with another difficult government task on the same issue. So I had to take both of the two presentations for them. So the first one was a study conducted with those are the authors, both from the University of Health and Allied Sciences in Dar es Salaam. And this was on screening of women for IPV at one of the municipal district hospital in Dar es Salaam. They aimed at to study the feasibility of using the abuse screening tool for women attending an outpatient department and describe how healthcare providers perceive its benefits and challenges. So that's our country, and you can see the blue arrow showing Dar es Salaam. I hope all of you know. Okay, so they had like 4 phases in this study. The first one was a planning phase, and this involved the selection of healthcare workers in preparing for other logistics for research to take off. And then the second phase was training of the healthcare workers, and they actually were training them on gender-based violence and orienting them on the screening tools and how to conduct motivation interviewing and how to write narratives. And the third phase was intervention, which was the actual screening of women, and the last was evaluation phase. So in the screening phase, like I said, they had a purposeful selection of healthcare workers to conduct screening, and they start based on the outpatient department, and the manager assisted to select 4 clinical officers and 1 medical doctor and 2 nurses to do the screening. And women who were selected for screening, due to the logistic reasons and confidentiality, the first 3 women attending the outpatient department were being selected from the 29th March to 17 April. And during the evaluation phase, during the screening, observations of healthcare workers and clients' interaction by the researcher, they were doing observation, and also the time spent with the clients. And after the screening, they did a 3 focus group discussion on perception of screening with 21 healthcare workers. and they had 2 focus group discussion which were mixed by sex and profession, and 1 focus group discussion which was homogeneous, only having female nurses. And then they had 5 written narratives from the 7 healthcare workers on views about conducting screening to women. So the results, they screened about 102 women, and 80 women turned out to report being abused, which was approximately 78%. And 50 among them had experienced intimate partner violence. 18 were abused by a relative, and 7 were abused by someone at work. 51 of the abused women had experienced the abuse more than once, and 18 of them were actually sexually abused. So in the focus group discussions that were run with the healthcare providers, there were 3 major themes emerged. One was asking how they, how they feel about the tool, and most of them, most of the report that they were giving that it was a blessing to have the tool. And the second theme, what next? There were issues about ethical dilemma, about screening women, and medical ethics, ethics of the nurses, and how far should they go asking women these questions, and issues of cultural issues and stuff. So those issues, there were issues that were emerging, and then there was issues of lack of resources. The third one was fear of becoming a women-only hospital, and this one is coming a lot. Actually, not only this study, even the other studies in Tanzania, the healthcare provider always fear screening only women for a normal health clinic, and also they always ask about what about men and children as well. So the implication, this study shows that the overall screening is beneficial and it's a stepping stone for other interventions. Other forms of violence can be recognized, and structural changes to be considered before screening. And studies on other forms of violence are needed. So I think I'll spare some minutes. I'll go to my second presentation. Sorry, the one who is... Can you please help me out? Okay, this one. So let me go to the second presentation. This is actually the program I'm also involved with. This is a program which is under Muhimbili University of Health and Allied Sciences. And we are trying to integrate GBV in different settings, in the healthcare settings, normal healthcare settings, normal clinics, and specifically for those areas that we previously trained on provider-initiated testing and counseling. And also we are trying to integrate in most at-risk population. So for this one, I'll just talking about the ones that we're integrating in provider-initiated testing and counseling. So in Tanzania, it's not very far from Kenya. It's nearly half of the women have experienced physical or sexual abuse. And gender-based violence increases HIV transmission, as you have all heard. Integration of gender-based violence to healthcare services is imperative to meet the needs, survivors, and also mitigate HIV transmission. So, the Muhimbili University of Health and Allied Sciences trained 80 healthcare providers from the 17 facilities in Dar es Salaam, and actually it was both from the public and private health facilities. And then they were trained on integrating gender-based violence into HIV counseling and testing, the provider-initiated HIV counseling and testing, and GBV management guidelines and other tools that were released at that time were used for training, and we used manuals, training manuals from the international manual. We actually had no Tanzanian manuals for training, so we used those ones for training them. And then they were given the tools to work on, the screening tools, minimal interventions, referral, reflex, and those kind of tools. So so the findings, we had initial lessons learned. We are still compiling the report. Actually, September is the last of this pilot program. So these are the initial findings from the pilot that we came up with. We learned that from the program that integration of GBV into existing HIV services is feasible, and a number of facilities were already providing GBV services to survivors actually, and the additional training was viewed as an instrumental for providing of standardized quality care. And the integration approach is promising in terms of strengthening response services and targeting a large number of hidden GBV survivors. However, we encountered a lot of challenges. One was the perceived extra workload, which led some of the providers to have negative attitude towards incorporating gender-based violence. And then the other one is it became as a new area, and usually it is not taught in the basic training of the healthcare providers, so it was something new, very challenging, and it was something that we felt like it required on-job training. And the critical human and material resources gaps, as you've all heard from the morning, exist. And also the space, the clinic space was too limited to provide necessary privacy and confidentiality. And there was lack of well-established referral and support networks for continuum of care. Although we provided few information of who is providing maybe more legal services, more psychosocial, we also have police who have a gender desk in police stations that we linked. We even have phone numbers and we give to the healthcare providers, but still, it was still difficult. That the system, the referral system is very difficult, and we find that most of the survivors will give up even before going. And we also saw a need for harmonized documentation system for GBV. In Tanzania, we all know GBV is not a diagnosis, so we don't have a system where GBV is documented. So we are lacking that, as you all heard in the morning. We are lacking, like, where should they document how much they screen, how much they give referral. And also questions about sustainability of integrated services. That's also a question. And we also see this, maybe you train a provider in this healthcare facility, maybe you had only one, only two in that facility, and then after some time they went for further studies or they've been shifted to another place. So that challenge is still coming, and we see it in our program. So in conclusion, we think integration of GBV into HIV services is promising, just like the first study, what they concluded. And we feel like further training should focus not only on screening and on provision of GBV services, but also healthcare providers' beliefs and attitudes. And this actually we have already addressed it, and we are preparing, developing training manuals, and we've incorporated that to include attitudinal issues because it came up a lot. And healthcare providers' basic training curricula should include GBV modules, maybe for sustainability, to help for sustaining and continuing of care for the future. And also mapping of the existing response services offered to people who have experienced violence in establishing referral and support network for continuum of care, and need for a harmonized documentation system for GBV. We've been crying for this, and I hope one day we'll be documenting and having more data on this. So thank you for your attention.
Thank you, Esther. I think this team of ladies has been great. We've actually managed to make up a bit of time. I'm now opening the floor to questions. Do I have questions from the floor? I think I'll be able to take like 5 or 6. It's only one. Any more? Okay, I think we'll start on